Thank you, everyone, and thank you, Erica, for kicking us off. I was going to ask folks if they could type their names and where they work, where they're joining us from today. So if you also feel comfortable adding location and your place of employment, that'd be awesome. Thank you so much. We're gonna go ahead and get started, Jackie, just to make sure that we honor folks' time who have joined us today, and other folks as they're coming in, we can just bring them in and fold them into the conversation. Sounds good? Okay, perfect. So good morning, good morning, afternoon, everybody. My name is Tanagra Melgarejo. I am part of the National Harm Reduction Coalition, and I'm joined today by my fabulous colleague, Jessica Smith. I'm gonna let her introduce herself.
Hi, my name is Jessica. I am the Community Mobilization Coordinator with NHRC, and I am up here in Arcata in Humboldt County.
Yes, Jessica is up north. I'm here in the East Bay in Oakland, and we will be your facilitators today for this Foundations of Harm Reduction training. I am going to have the closed captions to this as well. And for those of you that may not know, the National Harm Reduction Coalition, we're a national organization. We actually were founded here in the Bay Area in Oakland about 25, almost 26 years ago. And we were founded by people who use drugs for people that use drugs, folks that were concerned about the HIV pandemic at that time, and the fact that folks that use drugs were being left out of conversations about prevention, about services, and also about the implications of HIV in their lives, as well as stigma surrounding substance use and the impact of the war on drugs and the prison industrial complex on their lives. And so from that point, 25 years ago, we launched a North Star statement that reads that we create spaces for dialogue and action that help heal the harms caused by racialized drug policies. 25 years ago, we had those concerns. We see those concerns still today, and we still see the impact of those racialized drug policies in the lives and well-being of our communities, right, and the people that we love and care about. And we create those spaces for dialogue and action through different avenues, right? We have a really robust and mighty and powerful policy and advocacy team that are really invested in supporting communities to develop and promote policies and practices that fight against stigma, fight against criminalization, and really center the expertise of folks that use drugs. We also create spaces for convening through our national and regional conferences. Sadly, this year, we were meant to have our conference in San Juan, Puerto Rico, which is where I'm from, and we've had to postpone it until 2022. We're hoping we'll be able to be in person in 2022, but also acknowledging that, we're dealing with a worldwide pandemic, right? And so we're trying to create spaces virtually so we can continue to hold space for each other and to continue to be in community with one another. We also provide trainings like technical assistance, and this is part of one of those spaces that we're creating, this learning community with you all this morning. We also provide overdose prevention. We have we are actually the founders of the first community-based naloxone distribution program in the country, which is the DOPE Project. And the DOPE Project has served as an example for programs in other parts of the United States that are interested in distributing naloxone and putting it in the hands of the first responders, who are people that use drugs, their families and friends. And so we provide trainings. We also have advocacy spaces around that. And if you're interested in accessing naloxone here in the East Bay or where you're located, please, you can reach out to Jessica or myself, and we can connect you to folks that can make sure that you have access to it. And finally, we have many resources and publications that we have put together to support folks that are interested in expanding, developing, or sharing, harm reduction expertise and knowledge with their communities and in their spaces of work. I encourage you strongly to visit and peruse our website. We just went through a process of relaunching it with new branding, and we have, I think, created a space where folks can have access to our most popular resources, but also to resources that you can take and you can tailor to use in the context in which you're serving. So if you do that, just please give us credit, but otherwise take what you find. If it's useful to you, we encourage you to use it. And if there's something you're specifically looking for and you cannot find it, again, feel free to reach out to myself or Jessica, and if we have it, we'll share it. And if we don't know where it is, we'll make sure that we find the person that knows and we'll get it to you. I also want to ask folks, if you have any accessibility needs, to please direct message me or Jessica, and we'll be happy to try to address those. In this training today, we will be using closed captioning for folks. But if you have any other accessibility needs that you feel are important for us to know about, please let us know through direct message. Now I want to go over some Zoom housekeeping. I see that some folks have already begun to do this, but if you can add your name, if you haven't done so already, add your pronouns to your name. You can do that if you're in a computer by hovering over your little box that has your face and clicking the three dots. And there you'll find that the third item from the drop down is rename. And so you can rename yourself. That'd be awesome. And you can add your preferred gender pronouns. For folks that are mobile, you can click participants and then click your name and then rename. And you can add your pronouns on your name. We're going to ask folks to remain muted unless they're speaking, but we also want to encourage you to speak. So if you have anything to say that you feel is important for us to know, or you want to share thoughts, ideas, comments, we encourage that. We like that. We welcome that. Please feel free to do that. And if you're not sharing, then keep your mic muted so we can minimize, sometimes it has feedback and other ambient noises. Definitely also use the chat box or the chat menu to comment, as well as to see other folks' responses. We appreciate that folks sometimes feel more self-conscious about using their microphone. So if you feel more comfortable using the chat, we really want to encourage you to do that. And we'll be monitoring the chat closely to make sure that we're not missing any of your comments, as well as your fellow participants' comments. Zoom has they have several nifty emojis that they have come up with. They have added more and more, and we would love for you to use those as well to let us know how you're feeling, what your thoughts are. Please use those freely if you want to. And as we all know, in this new reality that we're in, which is very much virtual and technological, issues happen. And we will just try to roll with them as best as we can, knowing that, it's just part of our new reality. This is not a technological issue, but I do have a dog, and my dog doesn't necessarily like the person that brings the mail. So if she starts barking, I apologize in advance. I will make sure that I mute myself until she decides to stop doing that. So I apologize in advance for that. And please DM us if you have any accessibility needs, as I mentioned. In terms of what we're doing today, we have just gone through the workshop overview. And after we're finished with this, we will move right into defining what harm reduction is. And then we'll have a conversation about what the principles of harm reduction are and how, what they are and how we apply them. And then we'll move into unpacking the harms that folks may experience, particularly through a model called drug set and setting that we will share with you. And then finally, we will share strategies for harm reduction, right? What are some, what are harm reduction services? What do they look like? And how do we practice? How do we put those into practice? So that's what our agenda looks like today. And then we'll have some closing evaluations. I know Jackie will be sharing with you an evaluation form as part of the process for this training. So I want to ask folks if you have any questions, if this feels okay, anything you need me to review before we move into our actual training. You can use the chat box, or you can also, you can unmute yourself. And I also want to encourage folks, if at all possible, to, if you feel comfortable, to turn your camera on if you want. It's one of the things that I missed the most from my previous training life it was a bit in person and have that is like seeing people and like being in community with them and feeling that connection, right? And so if you feel comfortable and that's okay for you, we would love for you to turn your camera on. And also if part of your accessibility needs today is to have it off, we also understand. But regardless whether it's on or off, we encourage you to participate as much as you can. So thank you. So now we're going to move into the piece of what is harm reduction. Let's just really defining it and unpacking it. And I want to ask folks a question, and you can either unmute your mic to respond or you can type in the chat box, which is, why do you think we use drugs? Why do people use drugs? Yes?
Because
Go ahead.
I was going to say initially because they feel good and they create a positive response in the body.
Yeah, they feel good, right? It makes us feel good and our body feels good. Thank you, Malcolm. Elizabeth?
Hi, this is Elizabeth with 5 Keys, a day's hotel. Yes, I agree. Using drugs is a way of either blocking a feeling, and it also feels good.
Oh, yes, they feel good. They help us also. You mentioned something about blocking. Can you tell me more about that?
Yeah, sometimes you don't want to feel depressed. You want to block your sadness, anything you're going through in life. Struggles,
Mm-hmm.
and that's another form of numbing your feelings. And you use drugs as a sense
Yeah.
of comfort.
Yeah, so substances can be used to help us focus on something else, to divert attention from things that we may not feel ready or in a space to look at, right? To make us feel better. And that physical feeling also can translate to an emotional feeling, right? To a feeling of well-being that has to do with sometimes our hearts feel heavy, right? So substances can be used to ignore that sense of heavy feeling or not to look at it. Absolutely. And I see some folks are writing in the chat box self-medication. Other folks chatted the sense of numbing or not feeling, and folks, Erica just shared addiction, right? Like having a dependency on substances, right? We use drugs because not using them would feel not good, right? It would make us feel sick. Any other reasons why we use drugs that you can think of? Yes. To fit in, absolutely. To fit in with a group of folks, to create a sense of community. The same thing goes for having fun, right? Having fun with a group of folks, for recreation, particularly for exploration too, right? Sometimes we want to use drugs to see how it feels like, to look at reality from a different perspective, a different point of view, an altered state, right? That opens our minds and our brains to different experiences. Absolutely. Any other reason you can think of why folks use drugs? In terms of what your participants may have shared with you, what else have they shared in terms of why they use substances? Thank you, Erica. So it's sometimes we grow up in environments where folks, substance use is part of that reality. And we see other family members or community members, right, using substances. And then that can also lead us to want to experiment or explore substance use as well. Absolutely. Thank you for sharing that. Elizabeth, you want to share something?
How about peer pressure, like bullying?
Mm-hmm. Peer pressure, right? And I think that goes, I think you may have mentioned it or someone else mentioned it, to feel that you're part of a group, right? That you belong somewhere. And sometimes it's like what all my friends or folks in my community are doing, so I am also going to do it, right? Because I don't want to feel left out, or because I want to be part of something. I want to belong to something, right? And this may be the way for me to belong. Absolutely, as well. Yes, to build that community and that sense of being part of something. Thank you. And Eric is sharing that sometimes, with the legalization of some drugs, some folks may feel that it's more normalized, right? And so that's part of that other conversation, right? What does it mean, you know, to have access to certain substances? And that may feel more available to folks. And also, you know, what it means to use them in the context of a society, right, that criminalizes and penalizes us and shames us as well, and what that would look like. Thank you for sharing that. Now we're going to move to another question that I have for you. And that is, why is it that we just don't stop using drugs? Calm down, yeah. Desire to recapture the feeling of initial use and desire not to experience the negative side effects. Absolutely. Yeah, so sometimes it's like, this felt really good this first time. I want to see if I can feel that way again, right? And also, if I don't use, I feel sick. It doesn't feel good, right? For some other folks, it's the sense that without substances, I don't know what my center is, right? Because most of my experience and my existence has been grounded in substance use. So if I don't have support or ways to explore what it could look like without, or how could it look like with different substance use, then that can be really hard, right? If I don't know how to explore that or where I can safely explore it, that can be a challenge, certainly. And Eric is sharing with us that there's definitely brain chemistry changes that happen, right? And what does it mean when that brain chemistry change happens and I stop using? What would that mean for me? How is it that my brain now can produce, you know, and work in a way to compensate for that lack that it's there, right? That lack of, you know, the endorphins, the serotonin, all those things that, like, you know, our brain produces naturally, that sometimes when we use drugs, then substances take the place of, and now without them, you know, my brain is having a hard time figuring out how to do that again by itself. And as you can tell, I'm a social worker, not a neurological doctor. So I'm going to talk to you about it the way that I understand it. Absolutely. Yes. So there's brain chemistry changes that happen that make it really hard for folks to stop using drugs. What would be other reasons you think that folks don't stop just using? Yes, if folks stop, we need something to, you know, we need something else in place of that, right? Other coping skills or alternative medications, and sometimes it's really hard for folks to have access to those systems of care, right? Particularly access to behavioral health care, right? That doesn't judge them or kick them out because they're actively using or have used actively. And in terms of being able to develop coping mechanisms, one of the things that can be really challenging is, how do I do that in a space that feels safe, right? Because coping mechanisms, part of it is like, to figure out how to develop them, you have to feel comfortable practicing them and speaking about them, right? And if that is not something that you have access to, it can be really challenging. And substance use is a coping mechanism, right? It has helped people stay alive and survive, right, at this point. So we're asking me to give up something, the only thing that I know that has kept me safe and has kept me in this planet, and to give it up for what, right? Absolutely. Thank you for sharing that. Sometimes folks can't stop using drugs because they have become used to the way their life is with substance use, right? So my friends, my family, my community, right? Like, I am used to this experience, and how do I see myself being able to create or craft a different experience and a different reality, right? And that can be really difficult, because this is safety, because this is what I know, right? This is what I know works. This is what I know in this moment. This is the thing that gives my life structure, right? My life is structured in a way. And so if, for me to think about building an alternate structure to my life, I have to have the opportunity to talk about that, what that would look like. And also, it's an unknown. So I have to feel that I'm able to express the fear that may come from that. Absolutely. Thank you for sharing that. Any other thoughts about why people just don't stop using drugs? So now we're going to talk about harm reduction, right? So people use drugs and people don't stop using drugs for the same exact reasons. Because it feels good, because it has give them safety, because it gives them a sense of community, because it gives us a sense of belonging, because there's brain chemistry changes that have happened, because it has helped us to deal with trauma or not address trauma, because it feels too much to deal with it, right? Because we have mental health challenges or conditions, you know, that have become exacerbated of substance use is a way to self-medicate some of those, right? Because we need to stay awake for work, right? And or to be able to survive, particularly if I'm unhoused on the street, you know, staying up as a female identified person can mean safety for me, right? But then I need to be able to sleep. So maybe I use a substance that can help me sleep. We know that heroin is a substance that can help folks feel warm when it's really cold out, right? So there's different reasons why people use drugs and different reasons why people don't stop using drugs. And those reasons are the same for folks, right? And so now we want to look at what is harm reduction, because harm reduction is the tool that we can use that can get us to create a safe space, an honest space, a transparent space to unpack some of those reasons, to look at what's behind someone's motivation for substance use, right? What they see it's working for them and what they feel is challenging for them. And it allows them to be the protagonists of that conversation, right? Not us as facilitators or as providers, but it really centers them as the one who are driving that process and who are giving us that information so that we can listen and then find out ways that we can support folks if they need our support, right? So when we think of harm reduction is an approach, right? It's in two pieces, right? So harm reduction is an approach and it uses a spectrum of strategies that if we use them can certainly, it's been proven to reduce the negative consequences that are associated with drug use or with sex work or other behaviors that could be perceived as risky, right? And when we think of harm reduction as an approach, we can speak to folks about safer techniques. And I want to ask you, when you think of a safer technique around drug use, what comes to mind for you? What would be an example? Yes, new sterile syringes, right? So if I'm injecting, if I'm a drug, someone who uses their drugs via injection drug use, having access to new sterile equipment, hopefully for every single injection would be a safer technique. Absolutely. Thank you for sharing that, Malcolm. So that's one example, right? And we can think also of safer techniques, providing folks with access to new sterile equipment for snorting or for smoking their drugs as well. Just as we provide condoms for folks, and using condoms could be a safer technique. I see someone, Andrea, sharing test strips. Absolutely, fentanyl test strips. Andrea, can I put you on the spot and ask you to share a little bit about what you know about the fentanyl test strips?
Hi, can you hear me okay?
Yes.
Okay, there's a very loud heater in my office. So our team, we Healthcare for the Homeless contracts with a number of street health teams, and a lot of times we're able to partner with HAPAC, which is here in Oakland, because we're finding that a lot of the drugs, both methamphetamine and heroin, are being mixed with fentanyl, which could lead to unexpected overdose, particularly when people aren't expecting fentanyl to be there. So the test strips allow them to see actually what's in the drugs before they use them.
Absolutely. Thank you, Andrea. And having access to those strips gives power to people to understand and know what may be present in the substance. And that means that then if I know fentanyl is present, I can adapt my use in a way where I can be safer, right? Then I know that I need to have access to naloxone, that I may need to use lower or less quantity, right? Of the substance that I may not want to use alone. All of those things that are safer techniques, right? Absolutely. And I see Diana sharing with us in the chat box that supporting folks to transition substance use by supporting them with exploring harm reduction through other substances, right? Like I know, for example, there's folks that have found that they don't have a problematic relationship with marijuana, right? For example, and that actually marijuana has helped them to deal with anxiety, with symptomatology, right? With things that have come up for them that they have tried to manage or navigate with using substances that have become chaotic or problematic. So for some folks, it's saying, you know what, like marijuana use has helped me to stop using heroin, which I have perceived and know that can be a problematic substance for me. And so we're going to get more into that conversation in a little while, but I really appreciate that because that's also a safer technique, right? Thinking about, you know, instead of smoking, instead of injecting, maybe I want to smoke. Instead of injecting, I may want to snort my drugs because that way I'm not I'm not puncturing my skin and maybe creating a space for bacteria to come in for contracting Hep C or HIV. So thank you for sharing that. Then we have managed use, which is also another safer technique and is part of the harm reduction approach. And that means that for folks is navigating their substance use in a way that they feel doesn't interfere with their day-to-day life. For example, my colleague Emma Roberts shares that she used to work running a syringe access program in New York City, and she had a participant that would use, they had really horrible back pain, they've had an accident at their workplace, and their health insurance, as we know, in this country with many folks that have health insurance doesn't cover, it's not health insurance really, right? It's really difficult for folks, and he was injured, he wasn't able to get the treatment that he needed, and he started using heroin for his back pain. And so he would use a little bit in the morning, like he would use enough to feel good, to be able to go to work. And then he would use some heroin when he got back from work to be able to not feel pain, right? So here's someone who is using this substance to navigate their physical pain, that if it's present, it renders them unable to be able to work and meet their needs and their family's needs, right? So managed use, folks are able to use substances in the context of managed use, and their substance use is not interfering with their day-to-day life. And finally, there's abstinence. And abstinence means when folks choose to step away from using a substance, changing the way that they relate to that substance, where that substance is no longer part of their day-to-day life, right? When that substance is excluded from that reality, right? And for some folks, that's a really good avenue and answer. We in harm reduction believe in abstinence. It's an option for folks. It's an option that has worked for folks. And also it's an option that should not be forced like any other option, because it's not an option then. So we don't believe in abstinence be forced upon people. People need to make that choice, right? And think about behavior change for yourself, and when you have been told to stop doing something or using something, right? Sometimes if I'm not ready, I know for myself, it has felt really, really hard, right? And I've been successful maybe 2 weeks, 3 weeks, and then I've gone back and felt really crappy about it, because then I'm like, I failed, you know? And so part of what we are saying is we wanna have these conversations with folks when they're ready to have them, right? As I mentioned before, we're facilitators of processes. So if we open up the conversation and the person is ready and they tell us that they're ready, absolutely, right? But we're not going to push people into things if they're not ready, because then we're setting them up to fail, and that's harming them further. So when we think of harm reduction, that's the approach, right? Really centering the person we're working with as expert in their experience and as the ones driving the process. But harm reduction is also a movement, right? So harm reduction wants to pursue social justice, right? Harm reduction wants us and is asking us to have conversations about the intersections of oppressions in people's lives. What does it mean to live in a society that is xenophobic, right? That is colonialist, that has stolen lands from people, that continues to do so, that continues to harm our lands where we live, to poison us through toxicity, right? That continues to perpetuate racism and white supremacy and misogyny and trans and homophobia, right? So we want to address all of those things, because all of those things impacts people's reality and how they engage with substance use and how they can be harmed by substance use as well. So it's really thinking about social justice as the guiding principle in our conversations, right? We also want to make sure that we are addressing those and combating those, right? That we're actively combating those things, and we're engaging in different ways through our work experiences and personal experiences to challenge that, right? Whether it's conversations in the workplace, whether it's policy changes for us to be active in that. And it's really looking at the fact that, you know, there's interlocking struggles for folks. both against inequality and oppression that are central to both health and liberation, right? Like I think of COVID-19 as a perfect example of how flawed our systems are, but how well designed they are, right? Because they're meant to do exactly what they're doing, which is having people that are the most vulnerable be at risk, right? Being harmed. It's no surprise to me that my neighborhood is one of the neighborhoods in the East Bay that has the highest rates or cases of COVID-19, right? Because it's the neighborhood where people are essential workers, where people are unable to afford housing because housing is incredibly expensive because we don't have a minimum wage that it's realistic, because folks have to live, in spaces where they cannot physically distance, right? They don't have that luxury. And because a lot of the messaging around COVID-19 is in languages that they don't speak fluently or they don't feel comfortable in, right? And so all of those things are part of that perfect storm that is brewing, that is part of that inequality we're talking about, where folks, are getting exposed and harmed by a pandemic and by a federal system that doesn't have a response for it that takes that into account. And finally, harm reduction as a movement affirms the wisdom, dignity, and leadership of folks that have been most impacted by these harms, who are people that use drugs as keys to transformative change. We cannot do this work without the voices, the expertise, the knowledge, the wisdom of people that use drugs. And they have to be front and center in this movement. They should be front and center in this movement. And we should also, as part of our practice for justice, we also need to make sure that when we're having these conversations, that folks are not there as a token, but as experts in this process. And now I want us to think about shifting, right, from thinking about broadly about harm reduction, right? This idea of like, it's really philosophical, right? I want to ground us, like I want to bring us down, and then Jessica is going to move us through after this piece, another set of conversations in a moment. But it's thinking about the continuum of drug use, right? This is a tool that I have found really useful to help me understand substance use, but also to help me understand how nuanced it can be. Because sometimes what happens in society, I don't know if you've seen it, who here had to go through their education? I had to go through there. If you haven't, I encourage you to look at it. There, it's like, what is it? What is the acronym? There, done something, don't use drugs, something or something or other. I don't remember. I'll look it up. But basically, it told you if you smoke a joint this morning, by the afternoon, you're gonna be shooting up 10 bags of dope. Like, right? It's this idea that you do drugs once, and then you are gonna do them forever, and your life is spiraled out of control, and you are screwed, right? It's bad for you, and you're a bad person, right? That's my recollection of that drug education, right? And that's what a lot of folks have grown up with. And what the continuum of drug use tells us is that we, at any given point, can be in this space and we can move back and forth, and it's not black and white, it's not binary, and it's not dichotomous, right? That there's different ways that folks engage with different substances through this continuum, right? And depending on the circumstances, those things may look different. I have a friend, very dear friend, ex-harm reduction coalition colleague, also the person that knows the most about naloxone, maybe in the world. Her name is Eliza Wheeler. And I'm not saying this because, we were talking about it, and I'm sure she's fine with this. But she's used to be someone who has stopped using cigarettes for a long time. She had been abstinent from cigarettes for the past 10 years. And the other day we were on a call, and she said, I have to tell you something. It's like, I started smoking again. And I was like, and how do you feel about that? She's like, it feels great. This pandemic is driving me, it's the one thing that can help me cope with my anxiety. And she's like, and I know she was in no use at this end of the spectrum, and now she's in habitual daily. She's like, I know that if I want to stop, I can stop, because I stopped from 10 years. I also know that if I don't stop, I know that I don't need to stop. Like, I can sit in this space, and this is what is helping me cope. And COVID-19, it's a reality, that I'm dealing on a day-to-day basis in the work that I'm in. And this is something that is helping me. I find this helpful. And I can always move through this continuum, right, to a different place. And so that to me is an example of how circumstances impact, for example, the way that we're placed in this continuum, right? If I am someone who's curious and I am building community Experimental or situational substance use is a possibility, right? Like being in a new place with new people, trying something out, right? I can do it there, and then it may be like, this didn't do it for me, or wow, this is great, I want to keep doing it, right? And just thinking about where people place themselves. This is a tool for you to open conversation. This is not for us to tell Jessica, from what you're telling me, I think that you are in regular substance use, right? Because then that means that I'm decentering Jessica from the conversation, and I'm not opening the door for Jessica to really unpack for me what that looks like for her, right? Like, what do you mean by regular substance use? Like, what would that look like? How does your substance use look, right? Because Jessica may define it differently, right? And that's the point, that I want to work from her definition of where she's at, right? And she may be, and I'm using Jessica as an example, right? For us, it could mean like someone may have a drink every Friday, right? And may snort cocaine every Friday with friends, and then come Monday, it's fine, right? They don't do it until next Friday. And then maybe folks that, say to you, you know what, I cannot have Coke around me because once I do one line, that's it, I'm done for, right? And so that person has a different definition, and I need to be abstinent. I have to be in the no use end of that continuum. Alcohol, fine. I can have a beer, that's all good. But I have one line and that's it, I'm done, right? I do one bump and I am screwed. My paycheck's gone, right? Just thinking about how folks are building those definitions for themselves so we can understand, right? So we can listen and understand. I want to stop here for a second and ask you, are there any questions around the continual drug use or anything you want to bring up? Any thoughts? You find it useful? Yeah? So I encourage you to use it as a tool. You're welcome to borrow it. There's others as well that you can find and we can share with you. And it's a conversation opener, right? It's a way for us to have more understanding about how people see themselves and how people see their substance use, right? And for us to be able then to, from that place, see where they want to have us walk with them. So now I'm gonna pass it to Jessica, so you get a break from my voice and you get to hear her lovely voice as she walks us through the principles of harm reduction. I'll move the slides for you, Jessica.
Okay, perfect, thank you. So yeah, we're gonna get into the principles a little bit, and you will notice that Tanagra has hinted at a lot of them through the start of this presentation. And they're really beneficial because they are able to be rooted, right, in those approaches to harm reduction, but they also cover the movement part, right? I always think about harm reduction as like big H, big R, little h, little r. And the principles are really great for understanding both of them and applying them when we're doing the movement work of harm reduction and also the daily approaches providing services and using harm reduction techniques. Next slide, please. So we have 6 principles that we talk about and focus on for harm reduction. And again, as I start sort of talking in detail about these, you'll notice that Tanagra has really touched on them a lot. And they are often interconnected, interrelated, like they all sort of flow together. And I would say, like, I guess the main overarching of all of it is sort of this centering, right? When we talk about harm reduction, we're centering the voices and experiences of people who use drugs as experts in their own life. That's actually one very specific principle, but I would say generally, like, that is sort of the overarching theme, right? Obviously, besides reducing harms of activities and behaviors. So I will go through the 6 of them here. Health and dignity, we'll start there. So this principle establishes quality of life, quality of individual and community life and well-being as the criteria for successful interventions and policies, right? So again, Tanagra said, harm reduction absolutely supports abstinence if that is a decision that a person chooses for themselves. When we're thinking about health and dignity, we're not thinking of that as sort of this end goal, end all be all, like this is success and well-being. Because for some folks, maybe that's not the case. Maybe that trying to go for that goal is going to end up being more harmful in the long run. So really looking at the quality of that person's life, right? Having them tell us what it is that they understand to be quality, to be helpful, to be supportive to their health and their well-being, and also considering the community at large. Yeah. Any questions on that one? Can try to do questions, I guess, in bulk at the end of the principles. If you want to sort of think about, as we go through these in your own work, where you might already be utilizing that, or, you know, see it sort of in your day-to-day, and where maybe there's some room for improvement. So the next principle is participant-centered services. So this calls for the non-judgmental and non-coercive provision of services and resources to people who use drugs and the communities in which they live in order to assist them in reducing attendant harm. So again, right, we're centering the folks that we are working with. They are the experts. We're not trying to force them into doing anything that they're not ready to do. Even, you know, not forcing conversations that folks are not ready to have. If people come to you and, you know, they're asking or trying to address one issue of their health, and the first thing that you go through is like, great, I hear that concern, but like, let's talk about your substance use. And that's just not a conversation that they're even ready to have. That might deter them from coming back and seeking that care again. And also, if someone does come to you and they're ready to talk about that, ensuring that we're talking to folks about their substance use in a way that isn't going to stigmatize them, that's not going to make them feel shame for their behaviors, right? Really coming at them, meeting the person where they're at, understanding that their life and their situation is what it is in that moment. You might not have all of the pieces of their story, and hopefully building that trust with someone, you'll be able to get more of that and sort of understand where they're at and why they're there. But regardless of what folks are sharing, just making sure that we're approaching them as a person first and not judging their substance use, their sex work, any other behavior, like Tanagra said, that might be perceived as risky. And making sure that, yeah, we're not forcing folks into anything, any sort of service, treatment, conversation that they're just not ready for, because it can very well sort of stop that movement right where it's at, and maybe even, you know, prevent folks from accessing care further. Participant involvement. So this ensures that participants and communities impacted have a real voice in the creation of programs and policies designed to serve them. So this is a really important one for, I think, the work that a lot of healthcare professionals and just care providers should think about. And it often, unfortunately, doesn't happen a lot. I mean, think about like, even at like the big structural level, right? Like the policies that are in place, laws, regulations, how often is it that folks are included in the creation of these things, right? Like the criminalization of drugs, do we think that folks using drugs had a say in like how that sort of policy was created? So kind of bringing it down to the work that we might be doing. If you're creating like a healthcare plan for a client, making sure that they're involved, not sort of being paternalistic and saying, hey, this is what I think is going to be best for you. And this is, you know, this is the plan I'm creating for you, but being curious, right? Asking questions, asking folks what it is that they need. What do they think that, you know, is going to be realistic to accomplish, and sort of the time frame for that. Because folks are experts in their own life, right? Think about if someone were to tell you like, hey, I don't really know you all that well. I don't have every piece of info about like your life and your current situation, but I think this is probably the best choice for you, like to stop doing this, or, you know, reduce doing that. And how that might make you feel, right? You're like, I'm a grown-ass person, like I can make my own choices. So treating folks who use drugs the same way, and the communities as well, right? Broader communities, making sure that we're not creating, again, those sort of larger systemic policies that are going to negatively impact folks, but ensuring that their voices are actually heard. And we're seeing a lot of communities now, I mean, and always, but it's very visible right now, you know, stepping up and saying, we're tired of having other people tell us what is best for us. Like we are very much saying, we know, and we've been knowing, please, please, please listen to us. And we've seen that sort of the other approaches haven't worked thus far. So maybe it's time to actually listen to folks when they're saying, hey, we know what we need. we just need possibly the support and someone to listen and believe us so that we can start making those changes that we know are going to be best for us. Participant autonomy. So this one affirms participants themselves as the primary agents of change and seeks to empower participants to share information and support each other in strategies which meet their actual conditions of harm. So again, you'll see they're all a little similar. They're all kind of interrelated, and it really is just focusing on like autonomy, centering those voices and experiences. People know what they know what they need, they know what's going on in their lives. And we're just sort of there to be curious and ask the questions and see in what ways they're still needing support. Maybe they just need a sounding board, right? Sometimes it's great to be able to talk to someone and say, these are all the sort of options I see for myself. Like, what would that look like, right? And so, again, like I always think about this because harm reduction, like when you're doing it every day in direct services in like syringe exchange or anything like that, it can be challenging work, right? And we can see folks go through their experience, and sometimes, you can tell that people are not doing great. They're in a bad situation, they're not feeling well, and then maybe that changes in a week, but we really we care about humans, right? We do this work because we want to see people happy and healthy. And sometimes when that's not happening right away, we want to force our own will, right? Like, I really see you struggling. Like, this is what I know would help you feel better and do better. Like, I love you and care about you, and this is what I think is best. And even though like we care and love that person, that might just not be what's best for them. And so I always keep this sort of saying in my head, like, we are not responsible for anybody's successes or their failures, right? Like, we can't put it on ourselves. They are an autonomous human, and they have to be, ready and willing to do the work. And it might be a small change today, a small change next week, no changes for months. But if they're still engaging, right, if you build that trust and, remind them that like they have the power, they have the knowledge, they are the expert, and you're just sort of here to support in any way that they think is appropriate. Just sort of think about the times where you feel empowered and like how that's better than sort of someone saying, I'm not sure that you can do this. Like, maybe I should do it for you, versus no, like, I believe in you. You totally got this. Like, you know what you're doing. Just let me know if and when I can support. Sociocultural factors. So Tanagra talked about this earlier as well, but this one recognizes that the realities of various social inequalities affect both people's vulnerability to and capacity for effectively dealing with potential harm. We mentioned our North Star statement at the beginning, right? The whole war on drugs really speaks to this principle, right? We know that the war on drugs is a racialized war on drugs. If you are a Black or brown person, you are going to be more likely to be criminalized and put in jail for the same sort of substance use that a white person would do, or the same sort of like selling drugs, using drugs, right? Thinking also about your socioeconomic status. If you are unhoused, what that means for potential treatment, right? Maybe you've decided that you want to start Suboxone, right? Medication for opioid use disorder. And if you don't have that stability of housing, what does that mean for your capacity to be successful in treatment, right? And that success is obviously what that person determines. It might not be full abstinence. It might be managed use with the help of a medication. If you can't afford it, right? If you don't have insurance, or your insurance doesn't cover the kinds of medication or support that you needed, what does that mean for your access to treatment? I think some folks mentioned why people use drugs. If that's the sort of thing that you're growing up with, and that is what you're seeing, and there is no sort of support, or you're in a household where substance use creates trauma for you, maybe you were taken away from your parents, like, what does that mean for your future of substance use, or not, right? Maybe that impacts you in a positive way where you're like, whoa, like I saw the harms of that and it wasn't addressed. Like, I don't know that I'm going to do that. Or on the other side, like that's all I ever knew. And so that's how I'm going to continue. So again, like paying attention to these big structural issues, the sociocultural factors that not only impact, you know, somebody's use throughout, but the ways that they might be introduced to substance use and how that use might be impacted across the continuum, right? If you have more support, if you're, like some folks said, not trying to avoid feelings or address trauma or not address trauma, like what does that mean for where you fall at substance use, right? Like if I'm a person who always sort of recreationally use drugs experimentally, and I come from a family of like very severe intergenerational substance use, right? My mom was an injection drug user. My grandma raised me. And somehow magically, like those were not issues that I saw, but that somehow magically part, right, is my privilege, the capacity that I did have, right? I was never having to worry about being unhoused or like where my next meal was coming from. I am white, I am cis. So, you know, I have all of these privileges that put me at less risk for criminalization. I can easily try drugs and not have to worry about like, you know, being looked at like, oh, suspiciously, you know? So all of these things we have to take into account when we're considering folks' substance use and their vulnerability to effectively dealing with potential harms. All right, and then we have pragmatic and realistic. So harm reduction does not attempt to minimize or ignore the real and tragic harm and danger associated with licit and illicit drug use or other risk behaviors. Sometimes folks have this conception that harm reduction is just like, woo, drugs for everyone, like this is great, we want everyone to do drugs. And, you know, sometimes, like we said earlier, drugs can be fun, right? And maybe the harms, if we're educated and have the support and sort of the systems in place, the safety measures, like it can be, right? Fun and safe. But that doesn't mean that we don't also acknowledge that some substances can just be inherently more dangerous or routes of using can cause more harm, right? Again, Tanagra discussed how do you reduce harm. One of the ways, you know, switching from injecting to smoking or snorting, that is going to reduce someone's harm. So acknowledging that substance use in and of itself can present some harms, but often it is these other things, right? Stigma, fear, shame, criminalization, somebody not having the resources, the tools, the education, the safe place. And we're going to actually talk about this a little bit more when we get into risk set and setting. But all of those things can create more harm, can create situations where more harm might be present when maybe the substance itself or the route that you're using isn't necessarily as harmful.
Welcome back, everyone. I think maybe couple more folks coming in. I wanted to ask, how did that activity go? Would anybody care to share if folks identified a principle that resonated with them and why, or a principle that was challenging and why? You can unmute yourself or use your microphone.
Hi, this is Lauren Shirley.
Hi.
And I really respected and appreciated Jessica's your candidness in, you know, saying, hey, I've had these privileges to be able to use drugs within this setting and not necessarily you know, feel some of the consequences as other people would. So I just feel like how you just laid it out was, I love how you just owned it and it was beautiful.
Thanks.
Other folks that would like to share from their conversations in their small group, something that came up in terms of principles that either resonated or you found challenging?
I think in our group, or I know I've talked in our group a little bit about really like all of the principles make a lot of sense. And then as a social worker, sometimes having to navigate other systems who don't feel that way. And so you're held with this balance of trying to help somebody get this basic need met, yet, you know, like they wouldn't be okay with drug use, right? Like, and it's a very hard truth. And it's a very hard thing to hold sometimes, where you can be working with your client where they're at on where they're at with their substance use, and you can be having this great discussion at the same time. You'd love for them to be housed and have these other things. So it's kind of that's a challenge, definitely a challenge.
Yeah. Thank you for sharing that, Andrea. And I think that like part of also the piece that we can hold when we have these conversations is also being transparent with participants about holding that, right? The fact that we, you know, are trying to support them and do this work in a way that honors and centers them, their humanity, right? And their experience, and that sometimes there's systems that will make that challenging for us, and like really unpacking what that experience is like for them. And figuring out what are the ways in which we can collaborate or be co-conspirators with them, right, in some of those processes. And I really want to honor, you know, what you bring up, which is that, yes, this work is beautiful and messy and challenging a lot of the time. So thank you for that and sharing that very honestly. One more person that would like to share anything that showed up in your groups in terms of what resonated or things that you found challenging. You can use your microphone or type it in the chat box. Okay, well, we're gonna move on. And now we're gonna look at what are some of the harms that can come from using drugs. And I'm going to ask folks to either use your microphone or share in the chat box. What are some harms that can come from using drugs? Yeah, developing dependency or chronic substance use, poverty, lack of access to employment or losing employment, loss of family, sometimes loss of self for folks being unhoused, death. Absolutely, death because of accidental overdose, or death because of circumstances, you know, or systems that are related, you know, or interface or impact substance use for folks. Absolutely. Medical issues. Yes, Diana, can I put you in the spot and ask you what could be some examples of those medical issues and how they intersect?
Hepatitis C, heart problems, liver illness, problems with kidneys, teeth, problems with your teeth, and dental hygiene. Yeah, just to name a few.
Thank you. Thank you. Yeah, and those could be something that is a result of having, you know, engaging with substance use. And sometimes substance use folks may have experiencing pre-existing conditions, and substance use may also impact those, right? So it may be something that we're already experiencing, and substance use is just aggravating it, and there's things that stem from substance use. Absolutely. Thank you, Diana. Eric is sharing with us intersections around mental health and the impact of harms that can be caused for folks when they're using substances, right? Or maybe they are exacerbating mental health conditions that folks have experienced or are experiencing, right? Like such psychosis, for example, for some folks, or hallucinations, some of those things. Absolutely. Any other harms that you can think that can come from using drugs? Isolation, absolutely. Thank you for sharing that, Andrea. Yeah, loss of relationships and family for some folks. Also, when we think of, harms, is interfacing or interacting with the criminal and justice system and the impact that that has in people's lives, right? And like the long-term impacts of that as well. For folks, it could also mean like interfacing with child protective services as well. And that could be like there could be harms derived from that for the person. Absolutely. Thank you for sharing all of those. So now, Jessica and I want to walk you through this model. And like the continuum of substance use, this model is more than anything a tool to help us create conversation or spaces for conversation with people about their substance use. And if you want to look this up and learn more about it, I encourage you to do so. This is a model that was created by a social worker called Norm Simberg, and it is based on a long-term study. There's a how do you say that in English? There's a name for those studies, like they're long-term, longitudinal study. Thank you. Longitudinal study that he carried out with folks that have come back from Vietnam War. And so he thought, okay, I want to look at these folks and I want to look at their experience and how they're navigating substance use that started in Vietnam because of Vietnam, right? And so part of what he realized that he studied these folks for years was that I would say, and I don't know the percentages, we can look it up, like almost 90-something% of folks stopped using drugs on their own, right? They didn't have to go to treatment. As soon as they came back here and they found themselves with supports outside of the environment of the war, right? Not having to deal with the trauma and all that stuff that they were experiencing there on a day-to-day basis, eventually they stopped using drugs. That many of them identified being in that environment as the catalyst for having to use substances, right? And that having the supporting systems in place for them to access the resources that they needed was also something that helped them transition, right, from their substance use. And so one of the things that he thought about was like, okay, so we can translate that and look at this and really look at the context of the person and who that person is, as also parts of someone's substance use experience. A lot of the times we only center on the drug, right? And we're not looking at this holistically. And that's the gift that he gave us through the studies, right? The ability to look at substance use in a holistic way and to start understanding the intersections of people's identities in terms of how they manifest or can create harms in terms of someone's substance use, right? So yes, we do need to know about the drug, right? What is the drug that the person is using? And there's questions that we can ask, like how is it used? Like Erica, like we said before, and I think one of the folks in the chat box said, is it injected? Is it smoked? Is it snorted? Like how frequently are we using it, right? How frequently are we smoking, injecting it, or snorting it? Is it a drug that has been prescribed to us, right? Or is it a drug that we can find on the street, right? All of those things are things that are important for us to ask. Is information is important for us to gather so that we can have a conversation with folks about potential risks around their substance use. But just as important, if not more important, is really thinking about who is this person? What is their set? What is the mindset that this person brings to the situation, including thoughts, moods, and expectations, right? Is this someone who's struggling with trauma, with depression, with PTSD? Is this someone who's in a stable relationship with their community and their family in their lives, right? Or is this someone who has been uprooted or pushed out or pushed away, right? All of those things impact that mindset. And finally, the setting, which is the physical and social environment where the person is at, right? And their perception of how that environment can promote or reduce risk, right? So it's thinking about these things about like where that person is located, right? In terms of who they are and their location as a person. Is this person someone who lives in a community where they feel supported? Is this a person that is isolated? Is this a person that has access to resources because they are able to access transportation to be able to move back and forth, right? Is this someone who is housed or unhoused, right? Or if they're housed, how safely housed are they, right? What are the conditions that they're experiencing in that context, right, that can render them vulnerable to substance use, right? For example, I how, but if I am stigmatized because of my substance use, that can make my substance use more dangerous than if I was using outside with other folks, right? Or indoors by myself, but being able to call my friends to say, hey, could you check on me? If I don't respond in 10 minutes, that means that I'm in trouble, right? So it's really thinking about the set and the setting, having just the same weight as the substance itself, right? I want to open it to see if Jessica has any other things that she wants to add about this model that she would like to share with you all.
No, I mean, I think I was on both set and setting, you kind of covered what I was going to mention, but just, you know, thinking about as far as set goes, like for some folks, when they're feeling really bad, right, maybe they're really sad, they're really angry, and like the substance use is actually going to be more beneficial, right? They realize that like, I'm going to feel better. I'm going to calm down. Maybe like my behavior is going to change. Maybe they're feeling like so frustrated that like, I will be very transparent. When I get really angry, I want to like throw things and hit things. So for someone, maybe using that substance to calm down, like that is a better thing for them to do. And then on the other hand, if someone is in like the mindset of they're very depressed, they're feeling very down, and they do turn to substance use as coping, but it might actually impact that in a negative way, right? So also considering that, you know, we might think, again, in black and white of like, if you're feeling this way, you should or shouldn't do drugs. And if you're feeling that way, you know, maybe it's better if you do or don't do drugs, but it's going to be different for each person. And for, you know, setting is such an important one, right? Like folks having to use outside, unhoused people, there are just so many risks that then are, and harms that can be increased, whether it's fear of being arrested, not having like a clean place to use, feeling rushed, having people walk by and making, you know, stigmatizing comments. And then how being in that also then impacts that set, that mindset, right? So it's all kind of impacting each other.
So thinking about, for example, I have a colleague that gives this really good example, right? And we can think about it. So it's Friday afternoon. I am finishing work. I am going to stop by the supermarket. I'm going to buy a bottle of wine because I am going to serve myself a glass of wine when I get home, and I'm going to put on Netflix, right? So I am going to be drinking alcohol, and I am going to be at home, and I am ready to check. And that's a very different mindset and experience and setting. If I was going to go out with my colleagues for work, after work, we're going to happy hour, right? So I'm gonna like get ready to go, and I'm gonna have a good time, and I am probably not going to be home relaxing, right? Like I did with my Netflix. Right, I'm going to go out, so I'm going to be excited. I'm going to be meeting people. I'm going to be socializing in a different way. So it's the same substance, but different set and mindset, right, that we're bringing to the space. And I think like that's the piece that is important for us to create space for conversation with participants about, right? Not only about the drug itself, but about, you know, the mindset and the setting that they're in. Right, so we can understand how they see themselves and what are the things that they have identified already that could be potential challenges or risks. You know, so we encourage you to use this tool, take it from the slides and share it with your participants, you know, to engage them in conversation. And for you to be able to maybe, sometimes it's hard to start asking people about their substance use. So maybe this could be a tool that we can use to open that door to have more conversations about that. And now we want to share with you some harm reduction services, some things that are considered part of the spectrum of harm reduction services. And so we've talked about some of these already. For example, having syringe access and disposal. So that means giving people access to new sterile equipment. And that could also include, cookers, tourniquets, syringes, etc. But also tools to dispose of them so that folks can dispose of them safely, right? Is also providing folks safer drug use supplies, and that would include safer snorting kits and safer smoking kits, providing folks with overdose prevention materials, and that would include naloxone, which is a medication that can be used to revert the symptoms of an overdose, providing folks with safer sex materials, including condoms, lubricant, all that other stuff that can be part of that safer sex spectrum, providing folks referral for medication for opioid use disorder. Some programs, some harm reduction programs actually are really lucky to have also folks that are doctors that are, or nurse practitioners, I think, that are able to prescribe buprenorphine for folks and are able to dispense it right there. Some other folks prefer being referred to a clinic where they can receive methadone. So it's opening that door for conversation with folks, because people are different, right? And what works for me and feels good for me may feel different for someone else, right? And the important thing about harm reduction, if anything, is like this is like a buffet of options, right? Giving people as many options as they can to try on and see what they like feels good to them. Creating space for folks to be able to drop-in centers for me are one of the things that I find are really beautiful spaces to create community and build community, and also for folks to come in. And sometimes, as Jessica was saying, you know, I'm coming into the drop-in center not necessarily because I am concerned about my drug use, but I am concerned that I need an ID or I need a referral to be able to go to a gynecologist, or I need a referral for legal services, right? Or I'm coming in because I need to charge my phone and get a cup of coffee, right? And all of those things are and should be fine, right? And many folks, when I used to run a drop-in center, many of the community members loved it because it was part of the community and also safe space for them. And many of them didn't identify as people that use drugs, but still were part of, you know, engaging in services and coming and meeting other folks, and really creates a space where folks are seeing their full humanity, right? And seen as people, you know, not as their behaviors. And so having those spaces can be really powerful and also safe for folks. Housing first, where people, if they want to be housed, and having options for folks to be housed as well, and what are those options and how they can look like. Referrals to different kinds of services, and you can assess from your participants what they need and want. And finally, safer consumption services, which is a space. They have many of these in Europe and in Canada, where folks are able to go and use drugs in a safe environment. Most of them are staffed by people that use drugs, that have experience in navigating potential challenges or risks that can come, right? And you're able to have that space where people need to be revived, need to give an oxygen. Also, people are able to test their substances to make sure, as we were saying with the fentanyl test strips, to make sure that folks are able to know what is in their substance. And safe consumption spaces are also connected to referrals to other services. When people are ready, you know, because they trust you, they're able to ask, hey, I may want to be able to be referred for medication for opioid use disorder, or I want to be referred to treatment, or X, Y, and Z. So safer consumption services is also part of that umbrella of harm reduction services. I wonder if there's anything here that is not here, I'm sorry, that you think could be a harm reduction service that we haven't included. You can chat it in the chat box, or you can let us know by using your microphone. We have reproductive health services can be part of the harm reduction service structure. We can also look at legal services, particularly in communities where there's immigration challenges for folks. That can also be part of harm reduction services as well. Referral to employment services, food, folks that are experiencing food insecurity, referrals to spaces where they can have access to food security. All of those can be part of those harm reduction services.
I was going to mention pharmacy access as well, which I think we used to have on our slides, especially now with the passing of AB 2077, which continues the ability for pharmacists to legally provide adults over the age of 18 with syringes without a prescription. And so for some folks in communities that don't have syringe exchange or whose program might be facing pushback, having another option like a pharmacy for sterile syringes is a really great option and harm reduction tool. Not without its necessary, education, right? Because even though pharmacies and pharmacists are legally allowed to do this, not all of them want to, right? There's still that stigma around providing syringes to somebody who uses drugs. So great opportunity to not only educate the broader community about, reducing stigma and about the importance of sterile syringes, but then just also having that option, because there are lots of pharmacies and pharmacists who are totally on board and who are probably very happy that this it's been passed and they can continue providing these services.
Yeah, thank you, Jessica. We did have it in our slides, pharmacy access. So when we think of harm reduction or practicing harm reduction, you can be providing tools and services, but if you're doing that with stigma, with shame, without not centering people that use drugs, without keeping them uninformed and doing it in a way that minimizes their expertise, then that's not harm reduction. And you can be practicing harm reduction by treating people with dignity, with respect, with care, with love, right, with honesty. And you don't have to give out one syringe or one cooker to be, practicing harm reduction. So for us, the practice of harm reduction goes first with those principles, right? And that approach, and that's, tied or connected to tools and services. And that is the practice of harm reduction, right? Now, we're going to have a second opportunity for you all to be in small groups. And what we're going to do is that, and Jackie will be sharing this with you in the chat box as well. We're going to go into breakout groups again, and we want you to chat with each other about the following. How do you apply the principle of pragmatism and realism when helping someone apply for food assistance? How do you apply the principle of health and dignity when providing safer sex education? And finally, how do you apply the principle of participant autonomy when providing supportive housing? So we want you to go into those breakout groups and explore how would you, if you were providing this service, how would you apply the principle that is highlighted to be able to offer that service? Welcome back, everyone. It's good to see you back. Awesome. So what do you all talk about in your small groups? Can we have some volunteers share? What are some of the things that you all discussed? It can be any of the three that you found like, wow, this is getting spicy. What happened? We want to hear.
I guess I can go ahead and share. So on the first one, I stated as a case manager and a patient informs me that they are having a food insecurity, we do have a list of resources that we can give to them, but to ensure that the connection is made, a lot of times patients have a hard time navigating certain systems, or they're homeless and they don't have phones. So we really want to make sure that we are not just giving them the resource, but bridging the connection. So the practical thing would be okay, you have a food insecurity, let's conference call 211 and get you to the community food banks. Project Open Hands application, I faxed it over, but let me make sure that I'm speaking with a representative at Project Open Hands to make sure that they got this patient's application, and then confirm when they will start to be receiving meal, when they can start receiving meals. So it's not just saying, here you go, here it is. It's basically ensuring that the connection is made and that the food insecurity is addressed.
Mm-hmm.
So yeah, I'll just leave it there.
Awesome. Yeah, and that's such a great example of being pragmatic and realistic, right? It's understanding that there's structural inequalities that people experience, whereas for some folks, just knowing where to go is not necessarily going to end the situation of food insecurity, right? That sometimes is about, making sure that we're building that like connection and doing that warm handoff that you so beautifully explain how to do, Erica, right? Or really making sure that like that person feels, connected to the service, and also that they have a name, potentially someone there that they can ask, that they're connected in that way, that they feel that they know who to look for, right? And to make sure that we're having them go somewhere, that they're not going to waste, their trip, right? Sometimes, if we, they can show up there, as you well said, maybe the person didn't get the application, or they weren't able to fulfill it, to make sure that like the service was scheduled. So really making sure that we're minimizing, right, those potential harms for folks by being pragmatic and realistic in that way is super important. Thank you for sharing that, Erica. I really appreciated your example. Other folks want to share about your conversations in your small groups around the principles and how you apply them? You can use your microphone, or you can chat it in your chat box.
I think our teams also found it's always a very hands-on process for the same reasons. Like often it's more than just a referral. It might be a voucher to get to the DMV to get an ID, and a Lyft ride to get you over to the CalFresh office, or maybe you have literacy issues. Let me help you fill out the actual application, or maybe I could fax it in for you, or get a release of information to help you out. And in the meantime, what are some more local places that you can walk into to get food, like that have like donations for you, kind of all at the same time? And what is your preference, or simply just a lost card, which happens very often out on the street. Like we need to order you a new card. How do we do this?
Absolutely. And I think that you bring up, like hearing you speak, right, makes me think that we could change the principle, right? Like how do you apply the principle of being of health and dignity when someone is applying for food assistance, right? And so how do we apply that principle, or how you apply the principle of participant autonomy, right? And those things to me mean that like we still, in anything that we do, is centering the person. It's really listening to the person, and it's asking the person like what would be most helpful, right? Not assuming the person doesn't know, right? Like not assuming that someone is not informed about sex, safer sex education, right? It's about inquiring, like having a carrying curiosity, right? Like having that curiosity to ask folks, what is safer sex to you? What are some of the ways in which it can be challenging, right? And how can I be supportive? How can I be supportive when providing referrals to housing, right? Particularly supportive housing. And for some folks, what it's supportive housing is being with community members, right? It's being with people that they know, that they feel safe, right? And sometimes we're asking folks to move into one-person occupancies with new people that they don't know, and that feels really unsafe, right? So that may not feel supportive to them, right? So it's really trying to figure out what is in the best interest of the person, because this is what they're telling me would work best for them and make them feel safest in this moment, and keeping in touch with them, right? Maintaining that relationship. So if there's a change, or if there's a desire from the person to do things differently for themselves, that we're there to support them, right? So it's when we think about applying any of these principles, the most important piece here, right, is to really try to actively listen and to be present with the person, and to be as transparent and honest as we can about the things that we're able to offer, and the things that may be really challenging for us to offer as well, right? Sometimes the kind of supportive housing the person needs either doesn't exist, or it's unavailable, right? Or for the person to be able to access it, they need a requirement. They need to meet the requirement of being sober, right? And so it's really being transparent with the person and saying, hey, like I want to support you, but these are the things that they ask of whoever gets referred there. And how, if this is what you really want, how can I support you to get there? What are the things that you would need from me, right? And it may take a while, right? That's the other piece as well. Any thoughts or anything that folks want to add before we move towards our closing in terms of this exercise that may have come up for you? So when we're thinking of harm reduction, like I encourage you to think about the principles, right? And think about the ways in which your organization or you yourself are providing, tools. What tools are you providing that can be considered harm reduction, right? What are the things that you say, oh, wow, the way that I'm doing this embodies the principles of harm reduction? Think about one barrier that you find for yourself or in your place of employment within your team where you would have a difficulty implementing harm reduction in your work. And what is one opportunity, right? What is one place of possibility that you can identify in which you can practice implementing harm reduction principles into your work, right? I think we've all acknowledged that we're working under really, really challenging conditions, right? Conditions become challenging and they stay challenging. And I always feel that within those challenges, there's also spaces for possibility, right? And it's for us to be able to find those spaces of possibility and try to practice or engage in the practice of some of these principles, not only for participants, but also for us as providers, right? As Jessica said, sometimes we, very well said, a lot of the times we bear this burden of trying to feel responsible for people's outcomes, right? And that puts us in a really disadvantageous position, right? Because we are only able to be in control sometimes of our own outcomes, right? If possible, we cannot, it's hard to, for us, it makes it really hard to feel responsible for controlling people's outcomes, right? And so once as providers, we're able to let go of that and really center the person and center the things that they're doing well and the things that they're identifying as spaces for opportunity and possibility, then our work, I feel, sometimes becomes different. And it's in some ways a partnership, right, between us and the participants. So I encourage you with this exit activity to bring this back to your spaces of work, to share with your colleagues, and to really think through it, right, as a way of beginning to identify how harm reduction can play a role in the way that you offer your services. And so we're not Charles Hawthorne, so I apologize for that, but it's Jessica Antanaira. I'm going to, I want to see if this works before we go. I'm going to see if the video works because it's really cool. Hold on, let me share I have to share my computer sound. Okay, so I'm going to share that. Thank you, everyone. Thank you so much. Thank you for being with us. You will have access to the slides, and I know Jackie will be sharing with you an evaluation as well. I encourage you to fill those out and let us know what worked and what we could have done better. Thank you for being here this afternoon with us.